and several weeks ago they suffered from an outer ear infection, and I cleared the debris, and the doctors prescribed some antibiotic ear spray. We also took an ear swab just to confirm the presence of pseudomonas, a bacterial infection. So we were sure that they were getting the correct treatment, which they were. And their symptoms have since improved dramatically. If you watch that video 900, you'll see the ear canal it's quite swollen and inflamed. There's a lot of discharge otorrhea and a lot of dead skin coating the eardrum and the ear canal wall. I will put a link to that video in the description, so you guys can feel free to have a look at that as well. So despite their symptoms being almost alleviated, they did feel that it was slightly full, so a bit of what we call oral fullness. It was nothing significant. It's only because they know me, they asked me to have a look in their ears. Otherwise, they're coping fine. But interestingly, once I cleared the ear, they noticed a significant improvement. But it's similar to people who develop hearing loss, because it's a gradual benign condition. A lot of people with hearing loss, when they first come to have their hearing investigated, and then eventually have hearing aids fitted, they don't actually realise what they had lost until it's been given back. And similarly in this case, the patient felt they were generally doing okay, and it was only once I cleaned all this dead skin off the ear canal wall and also off the eardrum that they noticed a big improvement to their hearing. Now this is quite a difficult one, because so the infection's gone, but the residual discharge infection is almost crystallised, and that can happen with antibiotic ear spray. So that discharge, the wet keratin, infectious debris, once the antibiotic spray has done its job, that debris doesn't dissolve. It's still in the ear, and it crystallises, and it's like a piece of sharp glass or plastic even. And this is coating the entire ear canal wall. And if you continue to watch, you'll be quite surprised how much skin I actually end up removing from the ear canal. In fact, I would say that I provided a brand new layer of, there's a brand new ear canal that I revealed after removing the skin. And because this is quite a thick, crystallised layer of dead, infected skin, previously infected skin, should I say, I've just put some drops in there just to loosen this a bit, because I was finding it really hard to lift this off the canal wall. Now we've got to be careful as well, because we are on the bony part. You can see the ear canal narrows here, and this is the juncture between the cartilage and the bone. So anything beyond this narrowing is really sensitive. It's difficult to explain how sensitive this is, but I'm just thinking, sometimes if you've got exposed nerve in your tooth, for example, and you have something cold, it can really sting. And if you're not careful, if you put too much pressure on the bony part of the ear canal, because there's no fatty tissue, there's no cartilage here, it's literally bone, and you've got the thinnest of layers of skin that's attached itself to the bone. When that skin, the thickness is 0.01 of a mil, so it's 1/10 of a mil, should I say, so 0.1 millimeters. So it's really thin, and I'm going to upload a video hopefully tomorrow at the weekend, and you'll see in that procedure I used some forceps to try to get some skin off the bony part of the ear canal, and I slightly grazed that skin, and it ended up bleeding. Now it clotted almost immediately, so the patient didn't realise that I caught that the skin, but I grazed that layer of skin and it did bleed underneath. So we've got to be really cautious here. And you can see, you would think that this dead crystallised skin is just at the base of the ear canal, because it's visible, it's a dark brown colour. But once I do remove this, and it is tedious, we have to be really patient. You'll see there's also almost a hidden thick skin layer on the anterior canal wall. So the anterior canal wall in this case, so this is the patient's left ear, is onto the left hand side. I'm just gliding this fine end suction probe, just hovering it almost over the base of the ear canal, trying to ensure there's minimal contact. So I'm trying to lift it, but it is strongly adhered. There's quite a thick layer, so if it was a thinner layer, as I lift it off the canal wall, it will get suctioned in almost, but because it's thicker, the sheer weight of it, it flaps back down, almost like a trap door. So again, the entrance of the ear is a bit tricky because they've got quite a few cilia there, a few hairs. Now, I've lifted the bottom bit ever so slightly off the base of the ear canal, just giving me enough space to gently and carefully glide the bottom jaw of the forceps there underneath. And I was really hoping, after managing to carefully glide that into the ear and getting a grip, that I would get more of this dead skin out. I was hoping, in fact, it would all come out in one go, but it didn't. And what the forceps did, it just cut through the dead skin. So it just, a smallest piece of dead skin and this crystallized debris was removed. So I reverted back to the fine end suction probe. I will come back to the forceps a bit later on in the procedure, actually. So I've managed to remove all that crystallized dead skin off the posterior canal wall, so the right-hand side of the ear canal, and also the majority of the base of the ear canal. But there's still some left on the eardrum at the top, the superior part, which we are going to also move. And this portion here, so this is just the juncture between the cartilage and the bone. So the cartilaginous portion is the outer third of the ear canal, so the first centimetre, if you like, and the inner 2/3 is the bony part. And this skin is really, really strongly adhered. And I've just decided to go to the roof of the ear canal. Yeah, it's view is slightly obscured there, just because the entrance of this patient's ear is there's quite a lot of cilia there, a few hairs. So the top part of the eardrum has got a layer of skin. You can see the bottom layer, the bottom half of the eardrum you can see the eardrum quite vividly there. But the top part, there's like a masked layer of skin over it. So I'm just delicately approaching it. Now we're near the hammer bone, the handle of malleus. We're going towards the attic region of the eardrum now, so the pars flaccida, the top part. This is the very thin part, that's the thinnest part of the eardrum at the top. And I'm just hovering the fine end suction probe over the top. So I'm trying to avoid contact with the eardrum, just hovering it probably 1/2 mil away from it, and letting the suction power do the job. And you can see that's crystallized skin has detached itself from the eardrum. I think there's a bit left at the back part of the eardrum still, however. You can see there. So yeah, that is minimal, but I am going to go back and trying to get that out for the patient. So again, just trying to hover over. I've bent the tip of the fine end suction probe. You may see that at the distal end, there's a slight curvature there, and I artificially created that so I can get the angle. So what's remaining now is the front part of the ear canal. Again, to the untrained eye, you may not even realise that. It might look fine, but there is well, it appeared to be quite thin, but as I was removing it, it turned out to be a really, really thick layer. And at this point, I'm putting so much pressure with the suction probe, trying to lift it away. What's good with the fine end suction probe when we're removing dead skin and peeling off the canal, it has a double effect. Not only can you use the side wall of the fine end suction probe to almost, I've seen some videos where some specialists are using like a cawthorn hook or needle just to kind of graze the outside of the ear canal, bring the skin in. So not only does the fine end gouge have that ability, but the suction power itself, you can use that at the same time in conjunction with that and pull it away. But really and truly, I want to avoid, so because we're at the juncture here, I might be putting some pressure on the canal wall, but I want to minimise that. I'd rather just peel this without making contact with the canal wall. And I'm just trying to get underneath the skin, but it's so tightly adhered. Just trying to get underneath and lift it away, but I think I'm going to change angle of attack in a moment, because I don't think the skin, I could continue for a while, and I don't think it will budge from where I'm removing it at the moment. So I've just gone a bit lower, and you can see the angle of the fine end. I've angled it away, so it's going away from the back part of the ear canal, which reduces the risk of catching it inadvertently. And instead now, the side of the fine end suction probe is gliding against the bony part, so which is obviously a lot more tolerated. Sort of poking on the bony part, if we glide across it, it'd be less traumatic. So I'm just going to the almost the base of the ear canal now. So at this stage, the patient could hear, although they felt they were hearing really, really well prior to me performing the procedure, they felt they could hear a lot better. And interestingly enough, also, when I removed this layer, they felt there was a further benefit. Now, is that the placebo effect, or is there an acoustic advantage? So the ear canal, the function of the ear canal is to help funnel sounds in. So sound waves, they can travel through the ear canal and hit the eardrum. And it could well be that this keratin dead skin that's coating the canal wall, well, we know it does actually, it attenuates, it reflects away more high frequency sounds. So someone with otitis externus, an outer ear infection or inflammation, if you did a hearing test, typically you'll notice the higher frequencies response, it's somewhat diminished, because the skin either absorbs the high frequency sound, so it doesn't allow it to channel through, or it reflects it, so it reflects it back out of the ear, and creating a slight loss there in hearing in that frequency range. So I managed to remove some of the dead skin off the bottom, but there's still a lot more, and you may not realise that, it may not look like there is, but there is. And eventually I do remove this using forceps, but because I'm quite close to the eardrum now, before I want to use forceps, the aim here is actually just trying to lift the skin away from the canal wall. So I've got an opening, a space large enough for me to use the forceps to almost pincer this and remove it. Again, if this is a thinner layer of skin, the suction I'm using should be more than adequate just to release it from the canal, but this doesn't want to budge because it's really, really thick. And you maybe have some perspective there when you're watching that, you can just see how thick this layer of skin was. And even I was a bit surprised because it was almost translucent. You didn't see it when I was visualising the ear canal. I thought, this would be not straightforward. When you remove skin off the ear canal, it's always tricky. These are the procedures that I wouldn't have done when I first started, and it's the procedures I would strongly recommend against earwax delicates to attempt in the first instance. It's just too complicated, too complex. These procedures, you need to make sure you've got a steady hand, you've got experience and the skill, and that only comes with performing thousands of procedures. So I'm not afraid to admit that when I first started performing endoscopic dewaxing and clinical ear care, that this would probably be out of my capabilities. But with more and more experience, procedures, I feel pretty confident now that I can challenge the most complex procedures. In fact, this week I received 2 referrals of patients seen by other audiologists. One was in Leicestershire, where I'm based, and the other in Rugby, which is the neighbouring county. And I will try and upload those procedures over the course of the weekend, if not early next week. Again, I'm just come back to the juncture of the cartilage and bone, and trying to detach this a bit. I'm trying to lift it away slightly, even if it doesn't completely detach itself. I just want to create enough space. Now you can see now, I probably can glide the forceps underneath the bottom jaw and the top jaw on top. Now, the skin is actually making contact with the eardrum, so I'm just trying to manipulate this away from the eardrum as much as I can, because with the forceps I don't want to be pushing this further against the eardrum. So you can see I'm just trying to glide this away. So I'm hovering over the surface, then I'm trying to go underneath. It's really hard to get a suction grip more than I have. I think this is the best I'm going to do, and I'm going to use the forceps now if I'm correct. So it's very, the patient has got a very narrow ear canal as well, so it makes it tricky getting the forceps in the right angle. So I'm kind of almost, my hand's over the top of it. I've just pinched the bottom, I've just got enough grip, and I've managed to pull that out.